right? You have incredible quality of care when it works. But the working is not a problem with what's happening inside the clinic room. Inside the clinic room, the doctor, the nurse, the practitioner delivers good outcomes. Like, I mean, I've used the NHS. I know that's the case. But when you have the administrative and commercial functions, commercial not necessarily even in terms of revenue or profitability, just in terms of like focusing intensely on efficiency or on quality of experience all the way through a healthcare journey, you start to run into problems. And those problems manifest in ways that impact clinical care because you don't get the follow-up you need. You don't get so absent commercial, which is like a taboo word, but like absent a commercial focus, you end up with a very, very broken healthcare system. You know, to think about a restaurant, you go into a restaurant, you get incredible sushi, but the person who brings the sushi out is wearing a clown costume and drops the sushi on your lap when you get there. It's like great that, you know, you eat one piece off your leg, but like, you don't really get an experience. And this is the problem. It's like the whole experience of bringing the food out in a restaurant. That's the equivalent thing, right? Is that you have in the US, you talk about like, there's no clinic front door, like solving the problem of the healthcare front door. There's also no back door, but there's no healthcare front door because there's overinvestment, medical devices, new drugs, new development, all of the capital flows into improving what happens inside of the clinical pathway. But like accessibility issues span far beyond clinical pathway. So I think you have this issue, and that's what we say in like recruiting conversations here, right? Is that you have a business problem. That business problem is manifesting itself inside of a healthcare context. By the way, you have a business problem elsewhere as well. You probably have a business problem in education. You probably have a business problem in housing, all of which are slow moving sectors. They don't get lower cost with technology. Healthcare is one of them. So I think it's like solving this problem has the consequence of allowing people to provide better care. That's which makes it very worth doing.
So would you say that to have a thriving and is how to put it, effective or efficient and efficient healthcare system, the quality of care is only 20% of it or 10% of it. And the rest is actually the business ops, the workflow, the process, the effective aspect of that. What is your split?
Yeah, I don't think it's a split. Actually. So again, I'll take the restaurants as an example. You have two distinct parts of a restaurant. You have a kitchen, and then you have the experience of eating in the restaurant. The kitchen can produce 3 Michelin star food, and they can do that on repeat. If the experience of consuming that food is broken, then the restaurant doesn't work, right? And I think it's quite similar, which is that you can have the equivalent of the kitchen here is our clinical care, is the actual provision of so you can provide extraordinarily high quality care, as is the case in the NHS, as is the case in many practices. When you're inside the treatment room, magic. When you're not inside the treatment room, not magic. And so the clinical care is they don't cannibalize each other, right? It's not like I can either do high quality kitchen or high quality service. It's an and problem, not an or problem. I need to invest in my kitchen. I need to also invest in my service. Same way in the clinical context. I need to invest in what happens inside the treatment room, and I need to invest in what happens outside the treatment room. And everything is indexed to the former. The software that we use, the messaging that we use, the regulatory standards that we comply with, everything is indexed to, from a care quality commission, like CQC regulatory environment. They're very focused on the floor of the clinic room. The corner of the floor needs to be on a ramp so that you can clean it to a hygienic standard. Like, that's great. But what happens if the patient's sitting outside for 45 minutes? Where's the regulation on that? Where's the consideration of the patient experience? So there's this over focus on the clinical care because the risk is quite high. Like, if it goes badly, it really goes badly. But actually the patient experience is just as important. So I think it's an and thing, not an or thing.
And NHS, obviously, there are a lot of debate. It's a very controversial topic.
Yes.
NHS versus private. But what is your, let's say in short, what is your sort of view on public versus private healthcare, at least in the UK? Or maybe broader, like Europe as well.
Yeah, I think it's a both. I think, again, it's an and thing. I don't think that one system can exist in isolation. I think that there's natural reciprocity between the two of them. I know that in the UK right now, there's a large focus in investing in what they call community-based care or public-private partnerships. I think that is a natural way for the healthcare system to operate. There are different points of access, different ways in. Someone's healthcare journey is fundamentally different based on the reason or nature of their healthcare journey. Is it intervention-led and urgent? Is it entirely elective? I think having a single system, assuming that each of those is the same, doesn't make any sense. So I think there is a natural collaboration. There should be natural collaboration. And there's a lot of best practice that can and should move between the two. I don't know the extent to which that happens right now, but that is certainly an on-ramp for the sector to evolve.
Interesting. And what about your own experience as a clinic owner? What do you see the biggest, let's say if there's one thing you could have done better back in the days when you were running your own clinic, what would be the thing that, maybe one or maybe three, what would be the things that you would have done differently?
So when I opened the clinic, it was in the middle of COVID. Which was like the worst time to launch a high proximity face-to-face healthcare service. Could not be worse, right? Like doors opening for the first time. We had, the masks, the face shields, the gloves. We even had at one point, hygiene UV lights that were used in between each treatment to try and cleanse the room. We also ended up torching most of the plants that we have in the clinic because you put the UV light on the plant shrivels. So that was a learning that we had early on. So when we opened doors, we were very, very concerned about the way in which someone would move through the clinic. How much time would they spend where? What would the journey look like when they went downstairs to the treatment room, back up? Actually, before we opened, we did dry runs where we would have a fake customer come in. We would actually watch them move through the clinic all the way into the treatment room and back out of the treatment room. And we didn't realize is that experience actually should have happened before they came in the door. So all of that communication around what to expect, what happens when the customer, patient, could have actually self-directed. They could have made decisions for themselves based on what we in theory would have told them before they came in. And so we invested all this time in the in-clinic experience, but actually a huge amount of that was expectations management before and after the patient came in. And so that sort of communication layer, not your appointment is next Thursday. They know their appointment is next Thursday. Like they made the appointment. Of course, they know they often paid for the appointment. So they know that it happened before Thursday. So the question is, how do you get them to almost self-direct? And I think actually airlines do a really good job of this. They don't do a really good job of many other things, but they do a really good job of this, right? So you have a passenger who knows when to check in, what to bring, what not to bring. When someone gets to the airport, they almost self-serve all the way through onboarding. They have a few go through security here, go through security there, but they are very well informed of that experience. And there's also consistency, right, across all the airports that you go to. So in healthcare, you have this enormous moving target of sometimes you'll fill in your intake forms beforehand. Sometimes you'll fill in your intake forms there. Sometimes you'll do both because they have different intake forms. Sometimes you'll be asked this in clinic. Sometimes you'll be asked that in clinic. We didn't realize the amount to which and the extent to which we could move or front load all of that learning for the patient. And that required a total rethinking of the intake flow. It was no longer about clinical forms. Clinical forms was an admin item. It was the clinical experience. It wasn't the customer experience. So we had to do a lot of work to make that smoother so that patients coming into the practice had a really good sense of, here's what I'm here to do. Here's what I should expect. And here's how long I'll be here. Here are the questions I might have. And doing all that in advance of them arriving, really, really important. So that was sort of one of the big takeaways. The second one was actually on the way out. So the number of patients that walked out of our clinic without a next appointment was absolutely mind-blowing. Now, some cases, that's actually a really good thing. They had a healthcare problem, they came in, it was resolved, and they left. Happy days. Like, nothing is better in the world of healthcare than someone having a problem and leaving without that problem. But oftentimes, you have chronic conditions, you have follow-up appointments, you have next appointments in the course of a treatment. All of that stuff is absolutely critical to maintain. Keep patients on track so they don't slowly drift away. And so for us, what we found is that a lot of patients would get to the reception on the way out, and life is busy, and they say, I need a few days. I need 24 hours. Oh, I need a week to figure out when I'm next available. Or I'm traveling next week. Oh, my daughter is this. My son is that. I might have an issue with work. I might have a conflict. And oftentimes our response would be like, oh, no problem. Let us know when you have a sense. And then we might follow up with them by phone a week later, maybe 2 weeks later. And eventually that person would just disengage from the clinic. And so we had to put in place what we called ultimately was an exit tracker. And I'd recommend this for every clinic. Just have a very simple sheet. It can literally be pen and paper if that's what it needs to be, where every time someone walks out who doesn't have a next appointment, they simply become someone's job, right? And someone has to own that list. And oftentimes in clinic, this is one of the problems. Nobody owns that list. So you have the growing list at reception. Someone comes in on Tuesday morning. They look at the list. Ooh, it's busy today. I'll do that for Wednesday. Next person comes in on Wednesday. Ooh, that's growing even longer. I'll leave it for Thursday. And then 3 months later, the clinic owner, the clinic manager says, hold on a minute. Like, what happened to all those patients? And they'll go and they'll look at that list, and then they'll sit there and manually assign one by one by one by one by one to different team members. And then those team members will go out and make phone calls. But stopping that bleeding early on, you have to absolutely catch them. If you don't catch someone within 3 days of them leaving the clinic, the likelihood of them returning, again, drops off a cliff. So you have this 3-day window, maximum 72 hours, to go from they didn't know what their schedule was to now they have a next appointment. You have to close that window in that time. Absolutely mission critical.
And why do you think an outsourcing entity would be in the better position to help a clinic themselves to solve that problem?
Yeah, so I don't know if you ever watched like a youth team playing sports. So you have the situation where, you know, imagine a football team for, you know, kids 11, 12, and 13 years old. If the ball goes from the right side of the field to the left side of the field, everybody goes to the left side of the field. The right back, the right mid, the entire field shifts when the ball goes there. It's not like watching pro sports where the ball goes over there and people stay in their position. It's kind of like that, right? So when you have a healthcare clinic, and if you think about someone at reception desk, as soon as there is a weak point, as soon as the ball goes somewhere else in the clinic, the whole clinic team shifts. Someone's out sick. Someone's on holiday. Some issue with a room. The AC doesn't work. Everyone's being rescheduled. So you have this, it's one of the beautiful things about being in the clinic is that you're sort of in like collective flow when things are really going well. But there is always a problem. And so as soon as there's a problem in the clinic, the whole team shifts. Doctors out, nurses out, front of house is out, someone calls out sick, a patient has an issue, there's a customer complaint. And as soon as that happens, the entire day becomes around managing that issue while doing your day to day. That is exactly the problem, right? It's a beautiful thing that a team can be responsive in that way, but it is a huge problem because as soon as that space opens up and the whole team starts to move, nobody is focusing on the patients that are not red hot right in front of you. And so unless you move that outside of the clinic, unless you work with someone or find a way to dedicate someone to have full-time attention to that community of patients who are not right in front of you, who are not urgent, they will eventually disengage.
So the position of an outsourcing agency who is intrinsically not is like basically you wouldn't conduct surgery on your own son or daughter or yourself.
Totally. Exactly. That's right. Yeah, exactly. You've got someone whose job it is, and the thing that you get to hold them accountable to is that community of patients, right? So you have the people in clinic who are focusing on your reds and your bright oranges, people who are in front of you, people who are actively complaining, who have active care needs, and then everyone else, yellows, lime greens, greens, forest greens, all the way down to people you haven't seen in 3 years, they should be someone else's responsibility. Not because you shouldn't look after them, just how many people can you look after? When you've got a small clinic that's been open for 10 years, you're going to have 10,000 patients, 15,000 patients. You cannot support that number of patients. And the thing that's crazy today is that people say like, oh, AI solution. And I think you have a real problem there because AI, if applied well in a workflow that's established with really rich information and contextual understanding, great outcome. That is simply not the reality for many of our clinics. So you look at a clinic that, and we've had this happen with a customer, they will say, you know, let's focus on these patients. So we'll start working with those patients. And then a couple days later, they'll say, no, actually, we gave you the wrong people. But some of the people that were wrong, we actually rebooked, brought them back to the clinic. So inside of your own data, you don't know what's going on. So you introduce AI into that mix. It goes up like a house on fire. And this is why AI used well, like really effective. AI not used well, hugely problematic. And in our context, you really need to understand and have really rich data around where patients are in the journey. And we find that information is locked up inside the clinic team's head. It's not written down. It's not documented in the PMS. The PMS doesn't know That patient was away for 3 weeks. That patient had a family illness. That information is part of the customer service journey. So we need to extract that information and let that be the basis for re-engagement. Yeah. So when I was running the clinic, I think at one point in time we had 7 or 8 different ways of getting paid. You had people paying you in clinic on a card machine. You had people paying online with a booking deposit. You had people paying over the phone, people paying on SMS and email links. You had people on membership programs on direct debit or recurring payment. Then you had people wanting to finance their payment using some kind of BNPL solution. You had some people who are uninsured billing. So now you have an insurance component to that as well. And then you had some people who, this is where things really melt down, they had different payments at different parts of the journey. So they had an intake payment that was a booking deposit. Then they had a claims-based payment. Then they had a financing payment. Then they had a card payment. You try and join the dots across those payment methods. You have absolutely no idea who has paid you for what and when. And so you get to the end of the month and you are doing this musical spreadsheet job with your accountant or bookkeeper where you're trying to figure out what is the source of payments for different patients. So that's part of your issue, right? The other issue is that payments in healthcare are very different. They're different for a few reasons. The first reason is the patient body. Most people making payment in healthcare are, by comparison, lower risk to mainstream consumers, right? If you think about paying for something in a clinic versus buying a book online. Book online, you have absolutely no idea who the shopper is. You don't know who is making that purchase. You don't know where they are in the world. You don't know what card they're using. You have absolutely no sense of the risk profile associated. And so the fee level is according to that risk. It's pricing in that risk, oftentimes. In healthcare, you know this patient. Oftentimes you know this patient for years. Oftentimes they come in for years. Their family comes in for years. And you know with some degree of certainty that they will pay. And so the fact that you're being priced in a way that is even remotely related to generic unknown shopper makes no sense at all. So there's one issue which is purely based on pricing. The other big issue is that healthcare today runs on bank payment, which is a crazy thing to think. When I say bank payment, I literally mean like BACs. Send me invoice, enter details into bank account goes and transfers money. What's wild in healthcare is that when a patient is making that payment, they're sending it to the practice bank account. No administrators have visibility over the practice bank account. So now you've got a situation where an administrator is sending an invoice out to a patient. Patient is making payment to the practice. Administrator has no way of knowing that that payment has been made. So now the administrator has to send a note to the practitioner who has visibility over the bank account. Practitioner can then confirm or deny that the patient is paid. So you've got all of these touch points around the journey and the administrator is sitting there chasing. Has this person paid? Has this person paid? Has this person paid? Going back to the patient. Have you paid? Have you paid? Have you paid? It's insane. Like, obviously today you have open banking. Like, just connect the flows, right? So that doesn't need to be a problem. And yet it still is. And everyone is, in the industry seems to be over-indexed to free payment, free payment, free payment. BACS is free. It's not free. So we estimate £5 per touch point of cost. £5 per touch point of cost. What that means is if an administrator has to touch something, they have to check, write a note. Excuse me, have they paid? £5 of their time cost. Then the practitioner, another 1 minute of time to go into the bank statement, export it to PDF, send it over to the administrator. This is what happens. So you have this real breakdown between who's asking for and reconciling payment and who can actually see it. You see the same thing in payment links or in direct debit. We had a clinic that we worked with who, they had 400 or 500 monthly direct debits running, large subscription business, ongoing, great, stable revenue. The practitioner didn't feel comfortable for an administrative team to have access to go cardless. That was a showstopper for them. And so the only way to set up a new recurring membership payment was the practitioner to go in. When were they doing it? At dinner time. 8 p.m., 9 p.m., every night, new memberships, new updates, new changes, because the administrator team didn't have access to that portal because it's not fit for purpose. So you have a situation where you're trying to value optimize for 20 basis points, 30 basis points, and you're sacrificing dinner with your kids. That is literally the trade-off. And we see this in practices all over the place. Same with payment links. We had a dental practice. They were turning over about $2 million a year in payments. The dental practice owner, principal dentist, refused to let the administrative team send out payment links from Stripe. Wild. I mean, but this is reality. So now you've got a principal dentist who every minute that they're not in front of a patient is revenue loss for the practice. optimizing for some hairline basis point and security control because they're using a system that is not built for a healthcare environment. So you're using systems that are made for horizontal applications, systems that are used for e-commerce, trying to shove them into your healthcare practice. And now you've got 8, 9 different payment gateways, and you're in this runaround over and over and over again. You have no idea what you're paying for. You have no idea who's paying you for what. And it's one of the reasons why you've got some practices who are paying, I don't know, 3-4% in top line turnover in payments. Plus they have a book of bad debt. You've got patients who haven't paid you, not because they're bad, not because they don't want to pay you, because there's so much friction. You send them an invoice. They have to log into their account. They have to check the PDF. They have to look for the sort code. They have to look for the account number. They have to enter it in. Oh, but they entered the wrong account number. So now they have to, who has time for that? Nobody has time for that. So taking that friction out of the patient journey, making it so easy to pay is absolutely a must. There's no way around that.
It's the same problem across all clinics, different vertical, different type of clinics, right? It doesn't really matter. Or was there any nuance?
Look, it is. So as you move closer and closer to what we would call traditional or urgent or intervention-led healthcare, you typically get into more analog flows. Orthopedic surgery, respiratory physician, you typically find that you are paying insured billing plus BACS payment. And there is a huge amount of inefficiency, not only around the BACS payment, but also around the remittance from the insurer. You get into all kinds of complexity. On the elective care side, medical aesthetics, dentistry, you have a bit more self-pay volume. So it might very well be the case that you have fewer payment channels, or maybe you're using an integrated payment system with your booking management system, with your PMS. So it gets a bit easier. But the reality is that you don't need any kind of friction in the payment journey. Today, fortunately, people have solved that problem, right? You can secure a token for a card. You can then charge that card as and when you want to. You never need to ask your patient to pay you again. And wouldn't that be a joy if you didn't ever have to present a card terminal for them? You just think about the experience for a patient. They're in a treatment room. Someone's touching them, cutting them, opening them, hitting them, and then they get out to the front. It's like, for that wonderful experience you just had, where you are potentially now in pain, chiropractic, popping at your back. Now, please pay us for that experience. You're sending someone away from your clinic on some kind of aversion. You're having a disappointing event. Payment is never fun for anyone. So you're giving them this potentially good experience, something that's improving their healthcare. And then at the end, you're taking all that joy away by asking to pay you for it. It's not in any way the right sort of system for re-engaging that patient, keeping them happy. Much better to have them come in, have a wonderful experience, and then as they walk out, that's all settled for you. Hope you have a great afternoon. That's how you leave someone with a sense of, yes, I would like more of that experience, as opposed to the thing I'm going to remember most based on primacy and recency. The most recent experience I had when leaving that clinic is paying a few £100. Not a good outcome. Much rather leave them on a high than have them walk out the door feeling disappointed.
So it's more about the patient life cycle experience design. Payment is part of it, right?
Absolutely.
Obviously, payment, let's say if a patient keep coming back to one clinic or going to different clinics, payment is one touch point, but then there are obviously like how that patient being engaged with. There are many other aspects, but the whole dynamic is under that umbrella of life cycle experience or experience life cycle.
100%. So we work with a group. And they have multiple locations that will provide a joined up service. And they've done something really interesting. So they create what they call sort of a passport. That patient passport allows them to move between any one of their clinics and not to worry about payment. They can take payment at any point in that clinic journey. It doesn't matter where they go to, clinic A, clinic B, clinic C. They can take payment at the parent level. And that is a very thoughtful thing to do. It seems obvious, but it's a very thoughtful thing to do for a patient, because now you're giving them this idea of mobility and access. And that is critical in the life of a patient. So every time you put even the smallest amount of friction in front of the patient on their journey, you are introducing disengagement. That is a huge problem. You want them to move through your system in a circular manner as often as they need to complete their healthcare outcome with the fewest points of friction. Juxtapose that description. There's a clinic in the UK where they take card payment on exit with a terminal, but the terminal doesn't work half the time. And so they actually have to walk their patient out the front door in order to take payment when there's better reception, because there's no reception in your clinic front office, which, by the way, is something that happens quite a bit depending where the clinic is based. So now you've got maximum friction versus no friction. And that is going to impact your retention, your patient body. Not obviously, not in a way that you go home and think, oh, we've lost 55 patients this year because we put payment friction inside of their journey. It's not because of payment friction. It's because of all of the small parts of friction that compound and compound and compound and compound. And then suddenly you've got someone who cognitively, they're just not ready to make that extra decision. Oh, I can't be bothered to pay this right now because my card is in my wallet in the other room. No one has time for that. So you have to remove that friction in order to improve that end-to-end journey. And so oftentimes you have in clinic a clinic leader who has identified someone that they trust to lead the business. Sometimes that's a clinic manager. That clinic manager has an incredible amount of responsibility, almost an impossible amount of responsibility. They go from thing to thing to thing to thing to thing. There is no breathing room in their schedule to actually run the business. So if the clinic practitioner is in the room all day with patients and the clinic manager is putting out fires all day, who's building the business? Like, who's actually running the business? So you have this talent hole in the team. You know, in an organization, you might call it the COO. Where's the COO? The clinic manager is sort of the COO, but they're also the chief customer officer, and they're also the chief compliance officer, and they're also the chief procurement officer. They're doing all of these jobs wrapped up into one. And it's not like running a coffee shop. I would say, like, if you think about running a coffee shop, it is, if you have a choice between running a coffee shop and a clinic, coffee shop would be much easier. You've got one thing to do. People come in, you give them coffee, they pay you, they walk out. You send out an email once a month, do some cool stuff on social media, your job is done. It's a very straightforward customer delivery process. When you get into a clinical environment, it's just not. You have so much complexity wrapped into that, and people are not prepared for that. And so they sort of find their way into that knowledge, but there is no community, there is no support, there is no, oh, I'll call that person who's a practice manager over there. Sometimes you build that Rolodex yourself. But, you know, we host dinners for practice managers. We bring them together to try and get best practice to be shared. They don't have that support elsewhere. So there's an entire body of knowledge that is entirely, it's intangible. You can't actually lock that down anywhere. So I think there is in some ways an education component. There's also an accessibility component. How do you make this information available in a clinic context as opposed to a non-clinic context? Because you have to make the tweaks in order to make it specific to the clinical environment.
Yeah.
Let's rewind the clock. It was 1950. Right? B2B SaaS as a category, not really a thing. Nobody knows what it is. Healthcare still existed. People still had healthcare. 1950. 1850, they still had healthcare. People didn't have computer, didn't have technology, but it still existed. So to think that a practice management software or EMR, EHR is a requirement of providing care is wrong. Because of course, care was provided before software existed. So that category, PMS, EMR, EHR, became an efficiency tool. How do we continue to provide care, but do it in a more efficient way? And what I think is really interesting is what do the acronyms actually stand for, right? PMS, practice management software, EMR, electronic medical record. Neither of those descriptions are patient-centric. I mean, it's in the title, right? Like PMS, practice management software.
I thought it was patient management.
It's not patient management software. Some people will say PMS, patient management system. That's not what it is, right? It's a practice management software. And by the way, if you look at it, if you actually sit behind the screen and look at it, you will see that it is a practice management software. The screen that you look at is your calendar. That is your primary view. That is helping you manage your practice. The entirety of the system is built around practice efficiency, which is great because it helps and you need it. Put that in a box. Completely different than building something that is entirely patient-centric or customer-centric, right? Take the example of HubSpot, which is a CRM, customer relationship management. It presents you with a completely different kind of information. It focuses your attention on a completely different kind of information. There are some practice management software in the world that will advertise as a CRM, which is a category error, because if you go into that PMS and you start pressing the buttons, you will quickly come to realize that you cannot send out a message unless it is to a specific list with a specific criteria tagged in a specific way. So that does not allow you to do what you want to do. And so from a practice management perspective, it is a great enabler of efficiency. From a patient management perspective, it is often a great inhibitor of efficiency. And it's like hard to imagine that these things can't coexist. Because actually they should coexist, but these are very, very different workflows. In a similar way that if you look at, enterprise software, you don't use the same tool as your pipeline manager and your customer success tool. They provide fundamentally different functions. And so it's quite similar in a practice where you have a PMS or EMR EHR, which is really designated for the key user to be the practice, the healthcare provider, the organization. The key user is not the patient. And so when you start to think about patient relationship management or delivering patient relationship management, patient relationship magic, we call that internally, you start doing these unnatural things. You start trying to send things at weird times. You start realizing, oh, if I do this and I label them that way and I put this tag against them in my PMS, then I can get the message to go at the time that I want and the way that I want. It's forcing the software to do something unnatural, which doesn't mean that the PMS is not good at sending the appropriate reminders, ensuring that the patient is followed up with. There's a lot of great clinic and practice specific workflow that would be unmanageable for the clinic without that software. So it is absolutely critical, but it is actually different than a full service CRM. And so you will see clinics that have sort of come to terms with this reality, and they have doubled up. So they'll use a PMS and then they'll overlay something like Klaviyo, or they'll overlay something like HubSpot, neither of which are built for healthcare, both of which are email native, neither of which are necessarily focusing on SMS or WhatsApp-based optimization in their engagement with the patient. And they don't necessarily allow your front office team to have the control over that patient communication that they should have, because those pieces of software were built for B2B marketers. They were built for businesses that did not imagine a clinic context. And so we'll often say internally that PMS plus HubSpot plus your front office does not suddenly equal great retention. It does not suddenly equal great conversion in the way that it might in a more traditional B2B environment or even B2C environment, where you have the different business components stacked up to make it work. You think about a non-healthcare business, you might have someone who's responsible for driving customer relationship management with a HubSpot, but you might also then have a sales team. That sales team is specifically focused on conversion around that marketing activity. That doesn't exist in the clinic. So you can send all of the communication that you want, but if it's not coming back in a way that's revenue first, you're sort of just throwing money into a hole.